Yes, sir, we are live now.
Okay, thank you. So, good evening, all. Welcome to the another exciting and knowledgeable session of PEP, uh, Pediatric Endocrinology for the postgraduate. So, this program is brainchild of Professor Raghupati sir, who is very interested and in teaching postgraduates about the clinical skills. And this program is being hosted under the flagship of our Indian Society of Pediatric and Adolescent Endocrinology. So now I will request Dr. Haila ma'am, President ISPAE, to start the program, followed by Raghupati sir for the brief introduction of the program and aims and objective of this program. Haila ma'am, please.
Good evening, everyone. It's lovely to see all of you on a Wednesday evening, and thanks for joining this program. And as Dr. Jaivinda mentioned, Professor Raghupati sir's brainchild has actually grown leaps and bounds over the years. And we hope this program brings a lot of skills and interest in pediatric endocrinology, which has always been the dream for sir. And thanks to the support from ISPAE, and we are also deeply thankful to Dr. Amarnath and Dr. Jaivinda for taking this so well forward. And it's a wonderful occasion to see Professor Vijay Jaiswal, Professor Rajni Sharma, and Professor Sudharao here to teach all the postgraduates and encourage them in their interest in pediatric endocrinology. And welcome to all the students. And I hope you all have a wonderful and a fruitful session. Best wishes to all of you.
Thank you, ma'am. Thank you for the kind introduction.
Raghupati
sir, for the brief introduction of the program and your vision for starting this program.
Dear friends, it gives me great pleasure to be a part of this program. You're all aware that there is no teaching of pediatric endocrinology in many medical colleges. And you can imagine in places where DNB courses are held, there cannot be anybody to teach. But when the postgraduates appear for the exam, they are supposed to answer like specialists, both theory and practicals. So I thought there was a felt need, and we started humble beginning in 2012 in Bangalore, and we wanted it as a workshop, and we wanted a small number like 35 postgraduates. And we had so many applications, and we had to choose even in the very first attempt. Then we thought we'll make it a 2-yearly program. And in 2014, we had a very successful program in Coimbatore. And 2016, we wanted to, but we could not. 17, we had one very interesting program in Hyderabad. I was planning the next one in Kerala to cover South India, but unfortunately, COVID struck, and we could not do that. But I was able to infect Amarnath when we did the program in Hyderabad, and he arranged it in an excellent way. And after that, he has been doing it regularly. And instead of once in 2 years, now it's once in 3 months, you can see. And his continued interest, I'm really grateful for. And all the postgraduates I have felt have benefited immensely from this, because this is all from an exam point of view. And that was the whole idea. And I've heard postgraduates complimenting us for having such a program, and now it is once in 3 months, and that's also a very nice one. Thanks to Dr. Vijay and Jaivinda and of course Amarnath, and also to ISPAE for making this as a continuous ongoing program, and I'm sure the postgraduates will benefit. Thank you very much.
So thank you, sir, for your encouraging words. You always inspire us. So we will officially begin this program for today. So today we will be having one case presentation by Dr. Rishabh Gupta. So Dr. Rishabh is a second-year MD resident in LLRM Medical College. Rishabh has been guided by Dr. Vijay Jaiswal, who is professor and head at LLRM Medical College, Meerut. The examiner for the case is Dr. Rajni Sharma. So, ma'am is additional professor in pediatric endocrinology unit at AIIMS, Delhi. So, ma'am is is full of knowledge of pediatric endocrinology. She has lots of publications in field of pediatric endocrinology. We welcome Dr. Rajni Sharma, Dr. Vijay Jaiswal, and Dr. Rishabh. So, Dr. Rishabh, please, stage is yours. Please start this session.
Good morning, respected faculties. Myself, Dr. Rishabh. I am currently working as a second year resident in Department of Pediatrics in LLRM Medical College, Meerut. I am going to present the case of CAH on this eminent platform, Indian Society of Pediatric and Adolescent Endocrinology. Very good evening to my guide, Dr. Vijay Jaiswal sir, and examiner ma'am, Dr. Rajni Sharma ma'am. I'll start with the demographic details. Name of the baby, name of the patient was baby of Rosie. Date of birth was 26/11/21 and address was Meerut. Chief complaints. History is taken from mother and seems to be reliable. According to the mother, the baby got admitted with the chief complaints of abnormal looking genitalia since birth. History of presenting illness. A 2-day-old neonate presents with the chief complaints of atypical genitalia since birth. Baby was born at 38 week of gestation by LSCS at a private hospital with no complication. Apgar score was 7 and 8 respectively at 1 and 5 minutes, and birth weight was 2.9 kg. Doctors at hospital didn't reveal the gender and sent the patient to pediatric endocrinologist for review. Complaint of abnormal penis-like structure since birth. Negative history. There was no history of any male baby death in the family. No history of consanguinity. No history of genital ambiguity in siblings. No history of drug intake in mother. No history of recurrent infections. No history of irritability, vomiting, loose stools, lethargy. No history of seizures or abnormal movements. There was no history of facial dysmorphism and no history of edema. Family history. The baby was second born out of a non-consanguineous marriage. No history of any similar complaint in other family members. No history of ambiguous genitalia, acne, hirsutism, voice changes in elder siblings as per mother. No history of delayed puberty, amenorrhea, infertility, or any corrective urogenital surgery in family members. There was no history of early infancy death in the family. Immunization history. The baby was immunized at birth. BCG, OPV, and Hep B 0 doses were given. An injection vitamin K was given immediately after birth. Antenatal history. The age of conception was 29 years. It was an unplanned pregnancy. Pregnancy was confirmed by USG at 5th month of conception, which was normal. No UPT was performed. 2 doses of TT taken. No history of maternal virilization, acne, hirsutism, voice deepening, clitoromegaly during pregnancy. There was no history of fever with rash or radiation exposure in the entire pregnancy. No history of GDM, hypertension, hypothyroidism, or epilepsy. Weight gain was adequate during pregnancy. And at 5th month, the first antenatal scan was performed. Perinatal history. It was a second born child out of non-consanguineous marriage. G2, P1, L1, delivered via LFCS at 38 week of gestation. Baby cried immediately after birth. No loop of cord around neck or meconium stain liquor. Standard care was given to the baby. The baby was noted to have atypical genitalia. Feeding, breastfeeding as of now, frequency is every 2 to 3 hours. Socioeconomic history. As per modified Kuppuswamy scale, the family was in upper middle class. Summary on the basis of history. Baby of Rosie, second day of life, birth weight 2.9 kg, delivered at 38 week of gestation, term delivery via LSCS, uncomplicated, second born out of non-consanguineous marriage, presents with complaint of atypical genitalia since birth or at first day of life with hyperpigmentation of the genitalia, but without diarrhea, vomiting, or dehydration. Examination at
Yeah,
presentation.
Rishabh, well presented. Before we go on to examination, I just have few questions to ask. Can you go back to
Yes,
the
ma'am.
summary?
Yes, ma'am.
Yeah. So you say that complaining of atypical genitalia, you said that
Yes, ma'am.
the doctor did not reveal the gender. So what did the doctor say exactly to the parents?
When the doctor didn't reveal the gender directly, means they didn't confirm to the parents, so they didn't say that the baby was either male or female. They counseled the parents and asked them to go to a pediatric endocrinologist for the final verdict about the gender.
So exactly
And
what did they say? That the gender is not clear, that
yes,
we
ma'am.
do not know whether it is a male or female?
Yes, ma'am.
Is that what
They
they said?
weren't sure. Yes, ma'am. They weren't sure about the gender, and they said the exact same things to the parents that you need to that the gender isn't confirmed as of now.
Because of the atypical looking genitalia. But did the
Yes, ma'am.
parents
Because of
feel
the
that there was some did they assign any gender? They felt that it was a male or female.
ma'am, the parents were rearing the child as female. They considered the child as female after birth, just immediately after birth.
Okay, so for the
For the
parents,
first,
it was a female looking genitalia,
yes,
but
ma'am.
the doctor said that he's not
But the
sure about the gender
yes,
assignment. So they should
yes,
consult a pediatric endocrinologist. What was
yes,
the
ma'am.
reaction of the parents? Anything? Were they distressed,
Uh,
shocked, or
yes, ma'am. The initial reaction was, of course, a shocking one for the parents. Um, and but they were counseled by the doctors in a way that if they go to a pediatric endocrinologist timely, the treatment is possible, and the baby can sure lead a normal life.
the baby can surely?
Surely lead a normal life
Okay,
if a
okay.
timely treatment and timely intervention is taken.
Okay. Okay. And another thing that you mentioned here is that baby had diarrhea, no diarrhea, vomiting, dehydration. This is
Yes,
day
ma'am.
one of life or day two of life. So do we
Ma'am, this
expect
is
that
day
to
two.
happen? Yeah. Do we expect that
Uh,
to happen so soon?
no,
Just
ma'am.
a general
We don't
question.
expect.
Okay.
No, ma'am. We don't
Adrenal
expect diarrhea vomiting.
insufficiency. If you're
Yes, ma'am,
thinking
to
of
happen.
adrenal insufficiency in this
Yes,
child,
ma'am.
it would not occur immediately on the day one or day two,
We,
even up to the first week of life. Why is that so?
yes.
Why would that be so?
We No, it wouldn't happen that soon because these features are late. They present late in the neonate. I mean, they present usually after first week and they peak usually at 3 to 6 weeks.
Okay, but
Such
why?
features.
Any reason? You could suggest some physiological reason for that? Okay, we'll get back to that later. Maybe because the maternal hormones are there in the body.
Yes, ma'am. Due to
Okay, so
the
it would manifest a little
venous
later.
consumption. Yes, ma'am. They would manifest later due to the maternal influence.
Okay, you can continue.
Thank you. Examination at presentation. Examination was conducted in a well-lit room and after proper consent of the parents. The baby was crying. No signs of dullness or lethargy were appreciated. General examination was within normal limits. Heart rate was 146 beats per minute. Respiratory rate 46 per minute. Pulses were palpable. Temperature was 99 degrees Fahrenheit. SpO2 97% at room air. CRT was less than 3 seconds. And BP was 80 by 50, while the mean arterial pressure being 60 mmHg. No pallor, cyanosis, clubbing, edema was appreciated. Pigmentation of genitalia was noted to be darker than rest of the skin color. Head-to-toe examination. Hair were normal in appearance and texture. Cranium shape and size was normal. No obvious facial dimorphism was noted. Skin, hyperpigmentation of skin and genitalia was noticed. That was out of proportion to the rest of the skin. Eyes, ears, and nose were normal. Oral cavity was normal. No cleft lip of palate were appreciated. Hands, feet, and limbs were normal. Now, genitalia examination. Phallus length was 2.5 centimeter. Clitoromegaly was appreciated. Single urogenital opening was found at the base of the phallus. Scrotalized labia and rugosities over scrotal swelling were appreciated. Empty labioscrotal folds. Stretched phallus length was 2.5 centimeter. Hyperpigmented genitalia was seen, darker than rest of the skin tone. Anogenital ratio in our case was 0.6. Any value that is greater than 0.5 is significant and it requires further workup. Anthropometry at birth.
Rishabh, would
At
you like
birth,
to just would you like to tell how you measured? How did you ensure that there are no like gonadal swellings or any testes? How did you ensure that they're not palpable?
ma'am, by palpation, the scrotal folds were, the labioscrotal folds were found to be empty. There were no testicular structures palpable in that.
So did you only
And
palpate at the labioscrotal region?
ma'am, we palpated slightly above the labioscrotal region also, and no testicular swelling was just well palpable in the inguinal canal region also. And
Okay, so
later on, such finding was confirmed by the ultrasound also. There were no testicular structures found in the US.
you palpated at the inguinal ring as well
Yes, ma'am.
for any inguinal swellings, apart from the labioscrotal.
Apart
And
from the
you
labioscrotal.
occluded the external ring, so just to ensure that they would not, like if they were retractile testes, they would not get retracted
Yes, ma'am. They will not
prior to
slide
palpating.
up or get retracted.
And anogenital ratio, how did you measure this?
Ma'am, anogenital ratio is usually measured from the midpoint of the anus to the foreshoot. We take one value, and then from midpoint of the anus to the clitoris, and
The base of the
any
clitoris.
value, weight of the clitoris. Yes.
Yeah.
And any value that is greater than 0.5 is considered significant for ambiguity, and further work is
Why?
required in that direction.
Why does that suggest not ambiguity but virilization? Why does
Virilization.
the value higher value suggest virilization?
Ma'am, because the higher value would suggest virilization, because the abnormal clitoris or the phallus would come down, and the distance would become lesser. So the ratio in that sense would become higher. So that would
The
suggest
reason would be
virilization.
because the posterior labial fusion would occur. So when
Yes,
posterior labial fusion occurs, the distance from the anus to the fourchette would increase,
increase
and this would lead to increased anogenital ratio
ratio.
because of
Yes,
posterior labial fusion.
posterior labial fusion.
Okay, you can continue.
Thank you. Anthropometry at birth. The parameters suggested that the baby was appropriate for gestational age at genital examination. We did the Prater staging. Our case lied in P3 stage. Type 1, P1 is the clitoral hypertrophy. Type 2 is the clitoral hypertrophy. Urethral and vaginal orifices present, but were very near. Type 3, P3 were clitoral hypertrophy, single urogenital orifice, and posterior fusion of the labia majora. Type 4, penile clitoris, perineoscrotal hypospadia, complete fusion of labia majora. I'm so sorry for this. The light is uh, not there, so I'm so sorry for the disturbance.
No problem.
Type 4, penile clitoris, perineoscrotal hypospadia, complete fusion of labia majora. Type 5, P5, complete masculinization, normal looking male genitalia, but no palpable testes.
So your child had this child had P3. That
P3,
means
yes, ma'am.
there was a single urogenital orifice.
Yes, ma'am. A single urogenital orifice was appreciated at the at the posterior end of the phallus,
Okay.
the proximal end of the phallus.
Okay.
Now this is the schematic diagram of Prader staging, whereas the stage 0 suggests a normal female, stage 6 is a normal male, and 1 to 5 stages suggest various degrees of virilization. Our case was type 3. Systemic examination of all 4 systems were within normal limits. Summary. On the basis of history and examination. Baby of Rosie, second day of life, birth weight 2.9 kg, delivered at 38 week of gestation, term via LSCS, uncomplicated, second born out of non-consanguineous marriage, presents with complaint of atypical genitalia at 1 day of life with hyperpigmentation. On examination, phallus is of size 2.5 centimeter, labial fat is adequate, scrotalized labia is clean, no test is palpable in the scrotolabial folds. Provisional diagnosis, single term appropriate for gestational age with atypical genitalia, DSD, causes query CH with external genitalia of a male and internal genitalia of a female.
Can you go back, Rishabh?
Yes, ma'am.
So single term appropriate for gestational age with atypical genitalia, DST, cause CAH. First,
Yes, ma'am.
with external genitalia of a male, internal genitalia of female. So, first of all, I'd like to ask you, what is the definition of atypical genitalia? If you could just outline. Why do you say atypical genitalia in this child?
Ma'am, we said...
Just a second, Dr. Rajni. I request other postgraduates to participate actively. So it is for everyone. So there are other discussant postgraduates who should take active part. So please go ahead.
Why are we saying that this baby has atypical genitalia? What is the definition? It's the standard definition.
Ma'am,
okay, you can answer, Rishabh. Yeah. Yeah, go ahead,
Ma'am,
Rishabh.
we said... Yes, ma'am. The baby had atypical genitalia. We are saying this because there are, ma'am, both the left and right gonads weren't palpable at this point, and an abnormal phallus-like structure was seen. So, if either of the gonad was palpable, we wouldn't have said the atypical genitalia in this case.
Dr. Rishabh, ma'am is asking, sorry to interrupt, ma'am is asking that there is a definition when to say that this is DSD.
Okay, first give us the definition of DST. When you say a patient has DST, and what is the definition of atypical? So DST most commonly presents with atypical genitalia at birth, or it would present with abnormal pubertal development during puberty, either the two presentations. So what is the definition of DST, and what is the definition of atypical genitalia?
Others, please help him. Dr. Sriram, Dr. Ritika, and Dr. Ayushi. You can also answer.
So I would like to tell the definition of DSD. I am Ayushi. So DSD stands for differences in sex development, and it is a group of heterogeneous group of disorder which is characterized by atypical development of genetic, gonadal, or anatomic sex.
Okay, very good, Ayushi. Yeah, you're right. So there's a discrepancy between the genetic, that is the chromosomal, the gonadal, or the external genitalia. So we can say that atypical genitalia, most likely the cause is DST. So now Rishabh, tell me what is atypical about the genitalia in this case?
Ma'am, the atypical fact about the genitalia was that there was an abnormal phallus-like structure that was greater than 2.5 centimeters of length at examination.
So when you say in a girl there is clitoromegaly, right? So when do you call it clitoromegaly at birth?
Ma'am, the clitoromegaly at birth, we can suggest that greater than 1.5 centimeter length and greater than 1 centimeter of the corpora width. We say it is
1.5 centimeter would be 1 centimeter is the standard. 0.9 to 1 centimeter at
1
birth.
Centimeter at birth.
Yeah. And any other definition of atypical genitalia?
Ma'am, then
okay. So I guess we will be having a session on DST. right? Atypical genitalia. I'll be covering this later also. So we can continue. So in this child, basically clitoromegaly more than 1 centimeter in a female looking genitalia, or in a boy, if it is a boy, then length less than 2.5 centimeter.
2.5 centimeter is
Yeah.
abnormal.
And gonads are, bilateral gonads are not
Bilateral
palpable.
gonads are not palpable.
Right. And then there are various other definitions also, which we'll cover later. Okay, you can go on. Yeah,
Differential
so then
diagnosis.
this is a virilized female according to you,
Yes,
right?
ma'am. This is a virilized female. Yes.
Because you cannot see the, you
Be-
cannot feel the gonads.
The
You cannot
gonads,
feel the testes, so
bilateral
most
gonads.
likely it is a
Yes.
female.
Virilized female.
And which we confirmed from the ultrasound that there were no,
There were
which we
no
later
testes.
confirmed.
No
Okay.
testicular organs. Yes, ma'am. That
Right.
I'll confirm later in the USG findings. Differential diagnosis. Conditions that cause ambiguous genitalia. Virilized female, CH, that is the classic type 21 hydroxylase deficiency, 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency, or 3 beta hydroxysteroid dehydrogenase deficiency. Aromatase deficiency, gestational hyperandrogenism. Undervirilized male, for example, partial androgen insensitivity syndrome and 5 alpha reductase deficiency.
What do you mean by gestational hyperandrogenism?
Ma'am, gestational hyperandrogenism is
Ma'am, it is basically refers to a state of androgen excess that occurs during pregnancy, like
Yeah.
production via maternal ovaries and
Okay. Due
maternal
to,
adrenal glands as well.
so
And
it could be
sometimes there
a,
is, yes, ma'am, fetal adrenal glands are also involved sometimes.
okay, so it could be a maternal tumor, or it could be a luteoma of pregnancy, right? These are the things which can cause, and even aromatase deficiency would cause androgen excess in the mother,
androgen excess.
placental aromatase deficiency. Okay, continue.
These are the
Yeah, just one
investigations.
second. One more thing I noticed, just go back to your differential. You have written classic 21 hydroxylase, 11 beta hydroxylase, 17 alpha hydroxylase, and 3 beta hydroxysteroid dehydrogenase.
Steroid dehydrogenase.
Are you sure about all these? All these three
Ma'am,
things cause virilized female?
Ma'am, 17 alpha hydroxylase doesn't cause virilization at
Yeah,
infancy, so
it
it's not
causes
causing
undervirilized male.
It's causing undervirilization male primarily.
Yeah. Okay.
These are the investigations that we performed at second day of life. Blood sugar was 56 mg per dl, cortisol 4 microgram per deciliter, LH and FSH were 0.42 and 0.38 international units per liter respectively. 17 OHP level was 150 nanogram per ml at birth. For USG pelvis and karyotyping, they were sent and the reports were awaited. These are the investigations that I've charted in the form of
Just a second, Rishabh. With permission of Dr. Rajani, I want to ask you.
Yes.
What are the newborn screening tests we do and why we should do?
Sir, 17 OHP is the screening test for congenital adrenal hyperplasia of choice that we do in neonates. The usual trend is that at the day 1 or day 2 of life, the test is very higher and gradually the values fall as we start the treatment.
What are the other conditions they are tested along with the CAH? And what is the methodology used? Newborn screening. Others can answer, please.
So we use dried blood spot, dried
Very
blood
good.
for testing.
Which other tests are done apart from 17 OHP? You can switch on your camera, Ayushi. We'd like to see you.
Good evening, ma'am. Ma'am, like in this, like normally, so we also test for G6PD deficiencies and
Most important.
The commonest one, what we do?
no,
Yes,
not
go ahead.
thyroid, Thyroid,
Yeah,
sir.
thyroid,
Thyroid,
congenital
yes.
hypothyroidism,
Yes, sir.
TSH.
Yeah.
That is done on which day of life?
Yes,
After
that is more
72
important.
hours. After 72 hours.
After
Okay,
72
at
hours of
least after
cycle.
48 hours.
Day
At
3 or
least
day
after 48 hours. And Rishabh, you were saying 17 OHP on day 1. Can we
No,
do
ma'am, at
17
second day.
OHP on day 1?
No, ma'am, 17 OHP is not done on day 1. It is.
Okay.
Baby came to
It
you
should
on
be
day
done
2
later
only.
because normally also 17 OHP would be very high
Is
right
raised
after
on
birth,
day 1.
just like
Yes, ma'am.
TSH. So we would try to do
Yes.
it after 48 hours to get the
8 hours.
accurate value. And anyway, newborn screening is done after 48 hours. Once feeding is established, one TSH surge comes down, then we screen for all these conditions. Okay. Continue then.
Yeah, just a second. Rishabh, sorry
Yes.
to disturb you. So just tell me, CH in newborn, is a social emergency or a metabolic emergency or both?
Sir, it is kind of both.
What do you think?
CH on newborns is a both social and metabolic emergency. If
No, I'm telling your
say-
child is on day 1 presentation. You tell for both day 1
No,
or
sir,
what is the
it is
classical presentation?
Sir, on day 1, it is usually a social emergency more than metabolic emergencies. Basically, the adrenal crisis or the metabolic this functions are not present at day 1. They usually present after first week. And at day 1, it is usually a social emergency because the parents are so much concerned about the baby's gender. The usual questions asked by the mother and father from the doctor is the baby delivered is a male or a female. And so it is more of a social kind of emergency at day 1. Like,
Why it takes so much time for the metabolic emergency to manifest? Why
uh,
can't be in first day or first week of life?
So usually because of the influence of maternal hormones during the
Very good.
initial days of life, the metabolic emergency is present later, usually after first week, and they peak during the 3 to 6 weeks of life.
Yeah, Ayushi, can you tell what are the classical CH presents and how much percentage of the hormone should be absent or the enzyme should be absent? Means
So for
which
classical,
one is common, classical or non-classical?
so non-classical is common. The incidence of non-classical is 1 in 500 to 1 in 2000 births. And of classical, it's 1 in 1 lakh or 2 lakhs. So for classical, the hormone level should be either absent or 1 to 2% in the virilizing type. So it is the value is 1 to 2% of working hormone. And in
Ayushi, you said how much is the incidence of CH?
ma'am,
One in
for the non-classical, it is very common. 1 in 5,000 to 1 in 2,000 births, and for ma'am classical, it is 1 in it's 15,000 of 1,50,000. I'm not sure, but
10 to
that is
15,000.
rare.
I guess it's not that uncommon, just quite common. So if
10,000.
congenital hypothyroidism is 1 in 2,500, generally we say congenital hypothyroidism 1 in 2,500, which is the commonest. Then CH would be 1 in 10,000,
10,000 to
not
15.
that less.
Next
Not 1
question
in
to
1 lakh.
Ayushi
It's a
again.
quite a common disorder.
Yeah.
Chance of missing in common in male or female gender? Yes, Ayushi.
More
Chance
in
of
male.
missing it more in male gender. So
Why?
because so there is no ambiguous genitalia when a male child is born. So we miss it. But female, so the genitalia will be ambiguous. So we are very alert from the day 1.
Very good.
Yes. Okay, good.
Go ahead.
Okay.
Yeah, just I want to comment on these because if you are going to see the literature, there are so many undiagnosed reported death in male babies, and probably they were never male. Actually, they have not been diagnosed at the right time, and that's why it is really very important to screen all the babies who are going to be delivered, like congenital hypothyroidism. This is also very important, particularly for male looking at least.
Thank you, Vijay. Yeah, one question to Rishabh again. What is the one investigation single you want to do on day 1 of life CH baby if you're suspecting, which can solve your problems, as Vijay said, on day 1?
On day 1 of life.
Prabila has written
It's
AMH. Let's see the
and
comments.
Apart from 17 OHP, what is the investigation? So if you know the definition, you can answer. So external genitalia, internal genitalia, and
Yes.
the genetic sex should be
And
same.
that can be
Should be
done
same.
bedside. Dr. Rishabh, that can be done at bedside also.
sir, blood sugar is not usually.
No.
Yeah, someone answer ultrasound. Very, very
Yes.
important.
So Mullerian structure you are going to see actually.
Yes,
Yeah.
sir.
So
USG
And
can
testis,
be
if you can localize the
done.
testis also. Somebody has written, let me see, NS has written electrolyte and RBS. Because we know adrenal insufficiency won't manifest. Of course, you will do those tests, but it may not manifest so early. And another thing over here, karyotype. Yes, you would send the karyotype, but Rishabh, you have sent. How much time does it take for a karyotype to come? The report?
No, it takes
Turnover time.
two, uh, 2 to 3 days basically. The
Karyotype.
Yeah.
No, because you have to culture and it takes time. So how much time, average time does it take? It may take up to 1 month for the report to come. So anybody can suggest a quicker test, which you can get the chromosomal complement of the child quicker compared to karyotype is the gold standard, of course. But anything you can do meanwhile, a quick test, you can write in the chat box. So, yeah, Rishabh or Ayushi.
Y component is there some
one has written fish.
test. So what is that? Can anybody tell?
Somebody has written in chat fish.
Yeah.
Fish for what?
Fish. Yeah. So you
Fish
can do
for,
fish or you
for
can do
SRY.
even, yeah, or you can do PCR for SRY gene. Okay, so you can come to know whether there is any Y chromosome in the baby. And if there's no Y chromosome, then you can be sure that it can be a female most likely and counsel the parents. At least it will allay their anxiety. Okay. So fish you will get within 24 hours, 48 hours, you will get the report. And even PCR you will get very early.
And
Okay.
we have to wind up here already.
Yeah. So we're running late. So let's hurry up. Rishabh, we can go on.
Yes, ma'am. These are the USG findings that are summarized.
Okay.
The USG shows the presence of uterus. Ovaries weren't identified and no testicular structure was identified. The adrenal gland was hypertrophied. The adrenal length was 23 mm and lymph width was 6 mm. Genetic analysis, CYP21A2 gene analysis. 2 heterozygous variant in probable compound heterozygous state was detected, and karyotype report came out to be 46XX. Final diagnosis. Single term appropriate for gestational age with atypical genitalia, DSD, cause CH, 21 hydroxylase deficiency, with external genitalia of a male, internal genitalia of a female that was confirmed by USG, and karyotype came out to be 46XX.
Okay, I won't say external genitalia for male. You can just say virilized genitalia.
Virilized genitalia.
You can't say
Okay,
genitalia of a male, right?
right. Virilized genitalia, internal genitalia of a female, and karyotype 46XX.
So the most important thing, is it salt wasting or is it simple virilizing?
Ma'am, it is simple virilizing type. As of now, not of salt wasting type.
Okay, continue.
Now, treatment regimen. We gave oral hydrocortisone 3 times a day with total daily dosing of 15 mg per meter square per day. In our case, the patient's body surface area was 0.3 meter square. So the dose given was 5 mg total in 3 divided doses. Hydrocortisone has a short half-life and at physiological doses is associated with fewer side effects. While the dexamethasone and prednisolone has more growth suppressing effects in a neonate. Oral fluorocortisone was given as a dose of 100 microgram per day. Illness. The family was counseled to increase hydrocortisone doses when the child is unwell. For example, if the child is landing in dehydration, the child is suffering from diarrhea, fever, or vomiting.
So Hyzone, how did you give Hyzone? Did you
Ma'am,
dissolve the
Hyzone,
tablet? Or did you give it directly, crush the tablet?
ma'am, we crushed the tablet and gave it directly.
Okay, we avoid trying to dilute it because may
Yes,
get
ma'am.
left behind in the liquid. So you
In
always
liquids, yes,
crush
ma'am.
it and then,
We always crush it and give it in the powder form directly.
Can we stop here because these things you will be
okay.
covering in your lecture?
Yeah, we can stop here. So I'll be covering all this in my lecture. So well
Yes, ma'am.
presented, Rishabh. Very
Thank you so
nicely
much.
presented. Are
Thank
there any
you,
questions
Rishabh.
for Rishabh from anybody?
Yeah, nothing. One question for Rishabh. So, compared to CAH and adrenal insufficiency, what is the difference between the dosing of the hydrocortisone? Do you have any doubts how you want to give hydrocortisone?
Sir, when the child lands in crisis, the emergency doses are given usually, which are precipitated
That
by
is same
stress.
man. So, the case of CAH, another case of adrenal insufficiency, you are giving hydrocortisone. So, morning, afternoon, evening, you are dividing. So, when you
Yes,
want to
sir.
give more or less or same in three equal divided, and what is the
Sir,
physiology behind that?
Sir, in adrenal sufficiency, the doses can be as high as 60 to 80 mg per meter square per day. And in case of CAH, the doses can be from
Dr. Rishabh, Dr. Amarnath is asking, do you give all doses as equal doses or you want to keep some dose higher, some lesser?
sir, usually the morning doses are 1/3 and the evening doses are 2/3.
No,
The
Dr.
latest
Rishabh, you are not getting the question. Dr. Amarnath is asking whether there is some difference in the dose pattern in case of adrenal insufficiency versus CH.
Circadian rhythm. You know what is
Yeah.
circadian rhythm?
So
Okay,
probably
you read about that.
Dr.
sorry, I
Rajni is
don't.
going to
Yeah,
tell.
thank you. So I thank all the postgraduates for active participation, especially Dr. Vijay Jaiswal group for taking part. Over to you, madam. So we can go with the
Thank
lecture.
you.
Thank you.
I'll just share my slides.
Rishabh,
Rishabh, please
can you
stop.
stop sharing?
Yes.
Can you see my slides?
Yes,
Yes,
madam.
ma'am, your slides are there.
Slide starter mode.
Okay. Okay. So good evening, everyone. First of all, thank you very much, Dr. Amarnath, Dr. Vijay Jaiswal, Dr. Javinder, Dr. Raghupati, Dr. Ahila for the kind invitation. And so I'll be covering congenital adrenal hyperplasia and mainly covering 21 hydroxylase deficiency, which we just saw one case right now, covered very nicely by Rishabh. So it's purely from a postgraduate point of view. So as you all know, adrenal gland, it produces three hormones. The glomerulosa part produces mineralocorticoid, which is the salt hormone, fasciculata, glucocorticoid, which is known as the sugar hormone, and reticularis, androgens, which is the sex hormone. So all three are very important for the physiology, normal physiology. And CAH is an inherited disorder, autosomal recessive, due to enzymatic defect in the formation of cortisol in the adrenal gland. And 6 enzymes are responsible for production of cortisol in the adrenal gland. And the most common enzyme deficiency is 21 hydroxylase deficiency. So it is the leading cause of adrenal insufficiency in children, with an incidence of approximately 1 in 10,000 for live births. Now we'll cover the pathophysiology, clinical presentation, diagnosis, and treatment. So first of all, the first case of congenital adrenal hyperplasia was reported in 1865 by an Italian pathologist who found that there was a man who, very short man, who when he died suddenly at the age of 30 years, most likely due to adrenal insufficiency. And though the external genitalia were virilized, there was no testis, and the internal genitalia, internal female anatomy was typically of a female with all Mullerian structures and ovaries also present. So this is the first case of congenital adrenal hyperplasia. So it was basically a woman who was virilized, and it was known as adrenogenital syndrome. And the treatment with cortisone came almost after 1 century in 1965. Now, the 6 hormones which are, the 6 enzymes which are commonly involved are also the cytochrome P450, that is, they are membrane-bound enzymes, and they are the P450, which are very responsible for the production of cortisol. And the most common, as I said, is 21 hydroxylase, followed by 11 beta hydroxylase, 17 alpha hydroxylase, 3 beta hydroxysteroid dehydrogenase, type 2, STAR, that is the steroidogenic acute regulatory protein, which is responsible. This is a protein which is responsible for the carrying the cholesterol inside the mitochondria, where it is converted into the hormones. And P450, cholesterol side chain cleavage enzyme, which is known as SCC. Now, all these forms, what is so a little bit confusing is that all these forms have the classic and the non-classic forms. And the classic are the severe and the non-classic are the mild forms, depending on the level of the enzyme deficiency present. So it's a very variable presentation that can occur depending on which enzyme is involved and which pathway gets involved. So you can see that the cortisol deficiency ultimately leads to pituitary hypersecretion of ACTH, which stimulates the growth of the adrenal gland. And whichever is the precursor, which are proximal to the enzyme deficiency, they get accumulated and cause all the effects. Apart from this, as we know, ACTH is co-secreted with the melanocyte stimulating hormone, which causes hyperpigmentation. So now for postgraduates, it's very important to remember this pathway, because once you memorize this pathway, you will know which pathway is affected and which enzyme is getting affected. So as you can see, cholesterol getting converted to pregnenolone, progesterone, DOC, corticosterone, and aldosterone. This is the mineralocorticoid pathway. This one is the cortisol, glucocorticoid pathway. And this is the androgen pathway. So androstenedione is the one which is formed in the adrenal glands. And subsequently, it is converted to testosterone outside the adrenal glands. So now we can see that 21 hydroxylase is the most common. So followed by 11 beta hydroxylase, then 3 beta HSD, and then you have 17 alpha hydroxylase, which converts pregnenolone to 17 hydroxypregnenolone, and it's the same enzyme 1720 lyase, which ultimately forms DHEase, and androstenedione also. So we should know, if we know exactly which enzyme is involved, we can come to know that which one is the deficient hormone and which is the precursor which is getting accumulated, which will help us to make the diagnosis. So basically, I'm covering 21 hydroxylase. So as you can see, in 21 hydroxylase, it is the 17 hydroxyprogesterone which is getting accumulated, and all these things are getting shunted into the androgen pathway. No aldosterone is getting formed, no cortisol is getting formed, and everything is getting shunted into the androgen pathway. So 21 hydroxylase is the commonest, more than 90%. The incidence is very variable. Like I said, standard is 1 in 10,000. It's very high in certain groups like Alaskan Eskimos, where it is almost 1 in 300. So as we've seen, this due to this blockage, we'll have 17 hydroxyprogesterone getting accumulated. Now this is, as we were discussing, classic and non-classic types. So if the enzyme deficiency is severe, less than 1% of enzyme deficiency, it is the severe or the salt wasting type, in which even aldosterone is not formed. If there is even 1 to 3% enzyme activity, a little bit of aldosterone is formed, and there is no salt wasting per se. It is only accumulation of androgens, which leads to simple virilizing form, which is also a classic form. These two present in childhood. So salt wasting would present early in infancy, and simple virilizing would present in childhood. If the girl is virilized, she would present with ambiguous genitalia, and if it is a boy, he may present with precocious puberty. If even 3 to 5% of enzyme activity is present, depending on the type of mutation, it is a mild kind of a defect, and it presents as late onset CH or the non-classical type. In this, basically, women develop hirsutism, and it is a very common condition found later in life. So this is how we normally explain to the patients what is happening. So what we say is that normally in the adrenal gland, you're forming cortisol, aldosterone, and androgens. But here, there is a blockage at these two pathways. So these hormones are not formed and they have to be supplemented from outside. And this one is getting formed in excess. So there is excess of androgens. Now, 75% of the cases of CAH, the classic type, would be salt wasting. And they have defect in both the aldosterone and cortisol production with excess androgens. And they present with salt wasting and virilization very early in life. There is sodium loss from the kidney, hypovolemia, and hyperkalemia. Cortisol deficiency, basically cortisol is a sugar hormone, which is responsible for blood sugar production during fasting state. So whenever the child is ill, they're not able to, or fasting, vomiting, then the child is not able to form sugar. And at that time, they develop hypoglycemia during any kind of illness. There's poor cardiac contractility and decreased vascular tone, which can present as shock also. And shock is also due to hypovolemia due to mineralocorticoid deficiency. So the child will present with lethargy, poor feeding. There can be diarrhea, vomiting, dehydration, hypovolemic shock generally after the first week of life. The females have ambiguous genitalia and get picked up more easily. There is hyperpigmentation of the skin, especially genitalia, due to MSH, which is secreted with ACTH. Now, as we discussed, this is a very similar case, a 5-day-old infant with ambiguous genitalia, a phallus, which is small, a single opening and partial scrotal fusion with no testis palpable in the inguinal rings or in the labioscrotal folds. Develops vomiting and shock and has metabolic acidosis, hyponatremia and hyperkalemia. This is a typical clinical picture. So you can see here that this is the phallus, which is enlarged. The labioscrotal folds are very hyperpigmented. There is a single opening if you examine very carefully, and there is no gonad palpable. And we should always do the pre-adult staging in such cases. Stage 0 would be normal female and the normal male. Apart from this, there are 5 stages which occur in between. That is stage 1, which is the female with clitoromegaly. Stage 2 is slight posterior labial fusion with clitoromegaly. Stage 3 is the most important to recognize because generally they require surgical intervention. They have an enlarged clitoris with a single urogenital sinus. Stage 4 is predominantly a male-looking genitalia, but without gonads, and there is hypospadias. And stage 5 is a male-looking genitalia with normal placement of the urethral opening and without any gonads, but typically male-looking. So these cases may even get missed and be reared like males itself. This is the pictorial diagram, which Rishabh has also shown. So I'm not going into this, but you can see that this stage 3 is the most important, where there is fusion of the posterior labial folds, fusion, and there is a single opening, which is important to recognize. And this is only the presence of normal penile penis with a hypospadias. And this is normal male-looking genitalia without any gonads. Now, as we discussed, very important thing, when we see in our clinics, we see that there are a lot of girls and hardly a few boys, like 70 to 30 ratio. And why would that be so? As you already have mentioned, that most likely we are losing all the boys at birth itself due to adrenal crisis, and they're getting missed because they don't have ambiguity. They just present like sepsis and septic shock, and the diagnosis is not made. So girls are more likely to survive because they're recognized and treated. And it's very important that we do newborn screening because we don't want to miss out these boys. So as I mentioned, girls are more easily diagnosed due to ambiguous genitalia. It is missed in boys and it is mistaken for sepsis. Now, coming to the simple virilizing type, which is 25% of the cases of classic CAH are just simple virilizing. They have no salt wasting and they don't become sick, so they may not be recognized. Even sometimes the genital ambiguity is missed and it may not be detected at birth. And even sometimes the girls are being reared like males with the wrong sex of rearing. The salt wasting, non-salt wasting, simple virilizing CH types, the boys would have precocious puberty with development of pubic hair and phallic growth later in life, generally occurs after 2 to 3 years of age. And as you know, this is a peripheral form of precocity in which the testes remain immature and prepubertal in size. There is a rapid postnatal growth due to androgen excess in the boys and girls both. However, as we know, the final height is compromised because ultimately the excess of testosterone, which is getting converted into estrogen, leads to a fusion of the epiphyses. So this is a boy. As you can see, he is around a 4-year-old boy, but looking much older, much taller. And he is presented with precocious puberty, penile enlargement, but the testis is prepubertal. And you can see that he is, a lot of hyperpigmentation is present around the nipples, the skin, and the genitalia. So this is a simple virilizing CH in a boy. This is a 4-year-old girl. She has also simple virilizing CH, not present at birth. There's just a clitoromegaly. Another girl who is presented with clitoromegaly, and there is some pubic hair also present since the age of 6 years. So as I mentioned, some severe forms, that is Prader stage 4 or stage 5, they can be mistaken and be reared as boys. And the diagnosis is made at during the time of puberty, when they develop breast enlargement due to ovarian estrogen secretion. There's another 46XX being reared like a boy, but you can see that there are no gonads in the there are no testes in the scrotal sacs. So when there is a very mild enzyme deficiency, that is less than more than 5% of the enzyme is present, then the girls can just present with hirsutism in the peripubertal period. Now, when should you suspect the diagnosis of CH? When the patient presents with dehydration, shock, hyponatremia, hyperkalemia, any child with genital ambiguity, any newborn with bilateral cryptorchidism, or any boy with precocious puberty, you should suspect CH. Then the diagnosis is based on clinical history, examination, and a very important family history of previous sibling deaths or unexpected deaths may be present. Investigations include electrolyte, baseline cortisol, 17-OHP, testosterone, and if there is ambiguous genitalia, then karyotype and pelvic USG. Now coming to the 17-OHP levels, which is very much, as a postgraduate, I think you should be aware that the 17-OHP, the common test which is employed is the radioimmunoassay, but it's very non-specific due to cross-reactivity with other steroids in the body. So the gold standard is liquid chromatography, tandem mass spectrometry, HPLC, TMS, but this is not easily available. So you can still do the RAI test, but interpret it with caution, especially if you get normal values. And the 17-OHP usually exceeds 100 nanogram per ml in classic CH. If the value is a little, discrepant, or it's not very diagnostic, then you can go for a ACTH stimulation test. And in salt wasting CH, after giving ACTH injection, after 1 hour, you get values more than 1000 nanogram per ml. And in a simple virilizing or a non-salt wasting type, you would get values from 100 to 300 nanogram per ml. In the non-classical or the adult onset, you would get a baseline 17-OHP of 2 to 5 nanogram per ml, and post-ACTH more than 10. So these values can be diagnostic of the type of CH. Now coming to very important thing, if the baby is coming in adrenal crisis, how are you going to manage the neonate? First of all, you are going to give bolus of 20 ml per kg of normal saline boluses till the shock is recovered. Then you would start replacement with DNS, normal saline with 5% dextrose at 1.5 to 2 times maintenance. You would give hydrocortisone 100 mg per meter square per day in 4 divided doses. That comes out to be around 25 mg 6 hourly. You would manage the hyperkalemia and hypoglycemia if it is there. And the other thing is that always remember, when you're getting a baby with suspected CH, collect the sample of 17-OHP and cortisol before giving the first dose of hydrocortisone, and refrigerate the sample and send it to the lab later. Now coming to the treatment principles, we have to give glucocorticoids obviously for the cortisol deficiency. This will also help suppress ACTH secretion and the adrenal hyperplasia that has occurred. Hydrocortisone is the drug of choice because it is a short-acting drug and it has less growth suppressing effects. Once the child has grown up and epiphyses have fused, we can shift to a longer acting like prednisolone. Mineralocorticoids are used in salt wasters, and we can even give it in simple virilizing to decrease the hydrocortisone dose. We really have to balance the steroid dose, because if you give too less dose, it will lead to continuation of androgen production, virilization, advanced bone age, and ultimately to short stature. But if you give too much steroids, it would lead to poor linear growth, osteoporosis, and obesity. And close monitoring is required regarding the growth. So the dose of hydrocortisone is 10 to 15 mg per meter square in 2 or 3 divided doses, generally 3 divided doses. The physiological secretion is 6 to 8 mg per meter square. So almost a little more, almost double of that is required to suppress the androgen secretion. And as I mentioned, longer acting prednisolone can be used once the child has completed his growth. And like we were mentioning, normally we give the doses divided. In a normal child with adrenal insufficiency, we would mimic the physiological pattern. That is, give higher dose in the morning and lesser dose in the afternoon and evening. But sometimes in CH, we also follow this, but sometimes they may require higher evening dose just to suppress the androgen production. Now coming to mineralocorticoids, salt wasting CH, you always have to give mineralocorticoid. In newborns, they have aldosterone resistance, so we have to give even higher doses, up to even 2 to 3 tablets per day due to end organ resistance. And so this is one of the cases in which newborns require much higher dose compared to older children. And even though CH non-salt wasters have normal aldosterone, but they also benefit from addition of mineralocorticoid because it helps decreasing the dose of glucocorticoid. So normally we end up giving to all the patients. And always remember, Rishabh, you had mentioned in your patient you had given salt. Always give salt, 1 to 2 gram of table salt in the first 6 months of life till weaning is started and complementary feeds are started. Now coming to sick day management, which is very important, you have to explain to all the patients that they have to increase the glucocorticoid intake 2 to 3 times the maintenance during any febrile illness or diarrhea. And if the child is unable to take orally, give intramuscular hydrocortisone. So we normally teach all the parents how to give intramuscular hydrocortisone. The dose in infants is 25 milligram. In older children, it is 50 milligram. And in adolescents and older, it is 100 milligram stat dose. So all the parents should know how to use this, because many times we have seen in our country that they're not able to reach the local facility on time. They go into adrenal crisis, they start vomiting, they don't ingest their hydrocortisone dose, and suddenly they would have hypoglycemic seizure and even hyponatremic seizure, and it would lead to a very bad outcome. So always teach the parents and always reinforce in every visit the hydrocortisone injection. So once we are giving a very high dose of hydrocortisone, like more than 50 mg per meter square during adrenal crisis, we don't have to give flurinef, because that will act like a mineralocorticoid at those very high doses. And any dose less than 15 mg per meter square, then we have to add mineralocorticoid. So another aspect that we discussed, very important, was newborn screening. It is routinely done in all developed countries. Now we have started, in few hospitals are doing newborn screening for obviously for congenital hypothyroidism, it is recommended totally. And even in CH, people have started doing in India, and 17 OHP levels are done. And as we know, in the absence of newborn screening, it would lead to early neonatal deaths due to misdiagnosis. The follow-up is done clinically by measuring the height, weight, and BMI, blood pressure, which we try to maintain in the normal range. And the laboratory investigations, we monitor the electrolytes, 17-hydroxyprogesterone, which we try to keep less than 10 nanogram per ml. We can also measure androstenedione or testosterone and try to keep it in the normal range. And these levels are checked every 3 monthly in the infancy, and after that 4 to 12 monthly thereafter. But electrolytes should be done every 3 to 4 monthly in a salt waster. 17 OHP, as I mentioned, is kept at a range of around 1 to 10 nanogram per ml to prevent overtreatment with glucocorticoids. So now I would just like to conclude that the presence of ambiguous genitalia in the baby. One more thing I want to add was that we should be very sensitive while counseling the parents. Like you saw these parents, we have to be very sympathetic. We have to be empathetic, sensitive, and while counseling, and tell them that the baby, right now the sex is not clear, but once the investigations are done, the diagnosis will be clear, and the child has a good future and there will be a definite gender will be assigned to the baby. And we should not use any derogatory terms and be very careful. And the pediatric endocrinologist should be involved very early. Coming to sex of rearing, generally in a 46XX DST, best to assign them female gender because they have preserved fertility and possibility of surgical correction exists, and they generally have female gender identity. However, in our country, sometimes we see patients come very late at stage 4 or 5, who they have 4 or 5 prader, they come very late and they're being reared as males. In such conditions, it may be socially acceptable to continue as the male gender assignment. What about surgery for ambiguity? So generally patients stage 3 of prader staging with a single urogenital sinus would require surgical reconstruction, and it is a multi-stage procedure. So nowadays there is a moratorium on by many DST activists regarding reconstruction during childhood, but it is seen that feminizing genitoplasty generally helps give psychological benefit to the parents. So it could be done early if permissible, and the vaginal reconstruction can be done later in adolescence. So just want to add few things that you can remember that whenever you have a baby presenting in the emergency, always remember to collect the sample for 17-OHP and cortisol if you're suspecting the diagnosis, then administer the injection hydrocortisone. And examination of the genitalia should be thorough with the baby lying in the couch in proper lighting. Palpation of gonads is done. First of all, you have to occlude the superficial inguinal ring to prevent retractile testis from ascending, and then palpate the labioscrotal folds. So start from the up to down. Hyperpigmentation is a sign of CH. And the first thing that we all mentioned was ultrasound abdomen you have to do on the first day, and even enlargement of the adrenal glands could point to a diagnosis of CH. So 21-hydroxylase is the most common cause of 46XX DST, and there should be a high index of suspicion in newborns presenting with genital ambiguity for CH. Karyotype and ultrasound pelvis are the first line of investigations. Lack of palpable testis and not seen on the ultrasound also raises a suspicion of 46XX DST. 17-OHP and cortisol are key investigations, and appropriate management of adrenal insufficiency and even prevention of adrenal insufficiency is a must. And empathetic, sensitive counseling of the parents and guidance regarding the atypical genitalia is also very important. Thank you so much.
Thank you, Dr. Rajni. So we are ending this session with one comment and one question. Is any distinction question for all three candidates here? Please be alert, Dr. Ayushi, Dr. Vishab, and Dr. Ritika. So in course of CAH, 3 questions to you. So CAH patient can present with precocious puberty or delayed puberty or both. Second question, they can present with like a delayed bone age or advanced bone age. Third question, they can present with short stature or normal stature or tall stature. Yes, anyone? If you are unable to answer, think on these lines. Your teachers will answer this thing. So with Dr. Yes, answer.
So there is no light, but the patient will present with short stature because there will be premature closure of epiphyseal plates because of androgen excess. Then, sir, height velocity will be greater than 2 standard deviation compared to
if you are
age.
treating
Again,
properly or improper treatment, or you are giving less dose?
Sir, if improper treatment is there, then height velocity, sir, will be more. It will be more than standard 2 deviation, and there will be premature closure of epiphyseal plates. Because of that, short stature will be present. If male patient is there, then it will present with precocious puberty, and if female patient is there, then amenorrhea, delayed puberty, acne, hirsutism presentation will be like this.
Very good, very good. How will you treat?
Just a second, Ayushi, but they could present with tall stature also, no? Initial presentation because of excess androgens, they may be tall at presentation.
Yes,
Final height is short.
Yes, ma'am.
So this is a take-home message. We are also learning in all the lectures. So kindly see the patient till puberty, till adult stage. This is very, very important. I remember Raghupati sir's the take-home message I wanted to give. So we had a DSD clinic. So in that, one interesting thing I wanted to share with you, how a girl child is differentiated from the boy child based on the psychology. Can anyone answer? So usually female kids or the girls, they like the soft toys. So the liking towards and behavior also. So we used to have a advocate, we used to have a geneticist, pediatric surgeon, neonatologist, and pediatric endocrinologist. So this is called DSD clinic. So we are aiming for that. So please send all your cases to pediatric endocrinologist. Don't forget, and give full full-fledged this thing to them. So sometimes they send one time and again take back the patient. That's not correct. The take-home message to all pediatricians and also the postgraduates. Please don't do that. So I thank once again. It was an excellent program and it reached more than 150 students. I thank the whole team of Vijay Jaiswalji and also Dr. Rajani Sharma for giving short and sweet lecture and taking us into to heaven. So it was a very good lecture. I thank you. Now we are moving to the next part of the lecture, that is ASCII. With your permission, can I go to next, madam? Rajani, madam?
Yes. Yes. Thank you so much.
Vijay sir, any comments?
Yes. Ma'am, it was really excellent for postgraduate and it was exhaustive. And that is really required. Just I want to add one more thing, which is the saying of Dr. Raghupati sir, that irrespective of male or female, once you are being with at the time of delivery, that even for the female you have to palpate the labia. So that is really very important, and that can be a missed opportunity if you are not going to do, because these may patient very late going to present with some other problem. So it is very simple and it is not going to take much time. So this is my request, that please add one more examination finding at the time of birth in these newborns.
I have one request. Dr. Raghupati is there. So we
Yes.
want to, because sir is so experienced, we
Yes,
want
yes,
to
yes.
hear from sir that how
Yes.
you would counsel such a parent at birth.
Yes.
If sir could briefly tell us. Because many times we see that parents go into depression, shock when they hear. So how is the proper way of telling them, especially the postgraduates, if they are present at the birth of the baby? Sir is there. So sir can, with his experience, he can tell us that
Sir,
what would be
kindly
the
unmute,
most
sir.
appropriate.
Yes, sir. Thank you.
Actually, this produces a lot of emotional shock and depression in the parents, because they come up with the questions in their own mind. What have I produced? I don't even know whether it's a boy or a girl. And as was already mentioned, that initially we also used to think this is a medical emergency to handle and all that. But actually, it is not a medical emergency. From the emergency point of view, we need to gather as much evidence as possible from the radiology, ultrasonography, karyotype, and hormonal investigations. So many things are there. All of them should be gathered before we make a final decision. And but we tell the parents, reassure them that you are in safe hands and you need not worry. And I would have asked Rishabh this question. If you were available on the spot, what would you have done? Okay. And hiding the information is not the right thing. And you should say, we have a doubt. But most likely, this is going to be a male or female or whatever. And the quickest investigation, as was already mentioned during the session, is ultrasound. In a situation like this, ultrasound will give you the immediate answer that this is a female. And as you know, females are more affected in this condition. And so, if the uterus or Mullerian structures are present straight away, you get the answer that this is a female who's showing virilization. And I mean, I can go on talking about every aspect, but this is very important. We support the family as much as possible. give them all the right information, because there are many so-called doctors in the community who tell them all about eunuchs and very bleak outcome for the baby. And so we need to be very, very supportive. And we have a counselor who's trained in this area and who can be meeting the parents from time to time at regular intervals and offering them all possible um, help in understanding the disease. And the most important thing is also about the stress dose. Their parents should be educated and they should be able to handle the situation. And parental education is also very important.
Thank you, sir. Thank you very much.
Yeah, thank you everyone. I remember one lesson from Dr. Raghupati sir was go to radiologist, see whether it's a testis or the ovary based on the corticomedullary differentiation. So kindly go to radiologist and see. So I thank Raghupati sir from my heart and used to take many cases to the MD postgraduates and show. So it is the love behind the teaching is important. Now I request Professor Jaiswal sir take over. He has got many awards, best PG thesis award, and also from the government. Over to you, sir. So I request all postgraduate to be interactive in this session. There will be a case presentation or the question. You can answer the answers in the chat box, and other three postgraduates they can answer with unmuting your mic. So over to you, sir. All the
Thank
best.
you, Dr. Amarnath. My screen is visible to you?
Yes, yes.
Yes. So let us start after such a good presentation by Dr. Rajni, which has given all the answers actually. So yes. So in this picture, you can see here that there is single urogenital opening and there is labial fusion, posterior labial fusion. So can anybody tell me that what is the Prader stage in this case?
Stage 3, sir.
Good. So this is Prader stage 3 and this cartoon you have already seen. So I don't have to enumerate all the things, but yes, there are stages. That is 0 is female phenotype, normal clitoris, and there are various virilization process, and say male phenotype is stage 5 due to penile transformation, that is male phallus. So in between there is, but definitely from stage 3 Prader stage to stage 5, it is really to think that urogenital surgery or corrective surgery to be taken care. Yeah, now question 2, that growth inhibitory effect of prednisolone in compared to hydrocortisone, because we are caveat to manage all these cases of CAH before epiphyseal fusion, that is hydrocortisone. So why we are so much proponent for hydrocortisone? Because it is not going to influence the inhibitory, that is growth inhibition is not there. So can anybody tell me that what is the growth inhibitory effect of prednisolone in compared to hydrocortisone? How many times? So 5, 10, 15, 20? Yes? So in view of paucity of time, I am going to answer that is it 15 time having prednisolone is having 15 times more growth suppressive effect, that is growth inhibitory effect in comparison to hydrocortisone. And even dexamethasone is more worse in that, that is about 80 times growth suppressive effect in terms of if you are going to compare with hydrocortisone. The next question, that is known case of CH on treatment having mild fever and cough. And we have discussed that is sick day management, that in case of stress dosing. So what will be the hydrocortisone dosing for this situation? So known case of CH on hydrocortisone management.
Someone answered double
Yes.
dose. Dr. Rajani. QID? Someone answered.
50 to 100 in 4 divided doses.
Okay, so that question I have written purposely. So this is the answer, that we don't have to change any dose, because if the patient is having mild fever and cough, which is that is already the garden variety, so you don't have to change any dose. But yes, if disease is mild, moderate to severe, that is, if high grade fever, ARI, double the dose and the duration for 3 days. If high grade fever and the patient is sick, you have to increase the triple of the dose. It has to be continued for 3 days and double for another 3 days. And according to the status, you can reduce the de-escalate the dose of steroid. And in case of vomiting, diarrhea, and shock, so Dr. Rajni has already pointed out that depending upon the age of the baby, you have to, that is in infancy 25, in childhood 50, and beyond that 100 milligram per meter square per day, followed by oral stress dosing. So that is the way that in mild diseases, we don't have to give any stress dosing, even in a known case of CH. Now coming to question 4, it is really very important, as you have to relate the things, that an 8-year-old boy with early puberty and hypokalemia. So there is early puberty and dyslipidemia, that is hypokalemia. This boy was referred for early puberty in terms of underarm and pubic hair. Routine test demonstrated a potassium level that is 2.6, which is low. Blood pressure was elevated, that is 126 by 70 millimeter of mercury. And after the assessment, the boy was found to have cryptorchidism, that there was no gonads palpable, even in inguinal canal. And investigation, metabolic alkalosis and elevated DOC, deoxycorticosterone level, and karyotype was here done, and which was 46XS. So what can be the probable diagnosis in this case? Yes, any wild thought?
Someone has written 11 beta.
11 beta hydroxylase deficient.
Good. So 11 beta hydroxylase deficiency in a girl presenting with precocious puberty, in a boy due to severe virilization. So what is the message? That is, 11 hydroxylase deficiency should be suspected in boys with precocious puberty with hypertension. So it is really very important. And so if you are going to take any case of precocious, you have to take blood pressure. It is mandatory. Now coming to another question, that is day 3, child presented with DSD, diagnosed as 21 hydroxylase deficiency with discontinuation of treatment. And why this discontinuation was done? Because this was she was having Mullerian structure, 46XX karyotype, and all the things. But on monitoring, what they have seen, that hydrocortisone was discontinued because 17 OHP level remains very low despite reducing hydrocortisone. Now she presented at age of 14 years with delayed puberty, and on examination she had stage 1 breast development with stage 3 pubic hair, that is P3, atypical genitalia at birth, and delayed puberty suggests the combination of androgen excess and estrogen deficiency. And mother gave history of transient virilization during pregnancy. So this is dig out history, and can anybody help with that? What can go wrong with this patient?
Genajol, they have written.
Okay, no. So two things you have to, one, that is maternal virilization is also there. So yes, so that can be aromatase deficiency. So when to think that aromatase deficiency should be considered in a girl with atypical genitalia at birth, but there can be so many causes. But if you are going to have history of delayed puberty in the setting of maternal virilization, then you have to think for aromatase deficiency also. Now coming to the next, that is a 14-year-old girl with delayed puberty and hypertension. This girl was referred for evaluation of sexual infantilism. Workup showed high blood pressure, that is hypertensive. During assessment, so hypertension was done, and there was metabolic alkalosis, that is pH was 7.48, and showed inguinal gonads with high 18 DOC level. So what can be the probable diagnosis in this case? So sexual infantilism, 14-year-old girl with hypertension and metabolic alkalosis.
Deficiency, someone written.
Okay. So this is 17 hydroxylase deficiency. So the message is delayed puberty in a girl with bilateral gonad is suggestive of XY DSD due to 17 hydroxylase deficiency. Now coming to another interesting case that you can see here in this picture, that is this girl, normal stature for age, B5, that is Tanner stage 5, no underarm and pubic hair. Abdomen pelvic examination shows 1.5 to 2 centimeter mass in svelte left groin. No other abnormalities are noted. Rectal examination was normal. And external genitalia scanty of pubic hair, Tanner stage 2. And no abnormality. So what can be the probable diagnosis? That is B5 or Tanner stage 5 with some overt palpable structure in the left groin, that is inguinal region.
And CAS from someone.
Yes, good. So really, so commendable, that is complete androgen insensitivity syndrome. And that's why I was telling that this can be picked at birth, that is once you are going to attain the delivery. So it is, you have to make one added thing, that examine even in the female, that is palpation of the labial fold. Now coming to question 8, and deletion or inactivating mutation of DAX1 is associated. I think that I have put this for DNBs. So there can be hypergonadotropic hypogonadism, hypogonadotropic hypogonadism with congenital adrenal hypoplasia, obesity or diabetes. So DAX1 mutation or deletion can lead to yes. Okay. So hypogonadotropic hypogonadism along with congenital adrenal hypoplasia, because DAX is going to act on a very early path for the both. And you all know that these two things are going to govern with the same developmental process in the early part of the development, that is embryology. Now again, that is a preterm 10-year-old girl with failure to thrive and low cortisol level. This girl was born preterm at gestation of 28 weeks. Cortisol levels were 2.3 milligram per dl. This is milligram per dl. And she had prominent clitoris and normal electrolytes level. So what is your take on this case? So preterm with low cortisol level and prominent clitoris. Okay. So low cortisol level in a preterm child with normal electrolytes suggests transient hypercortisolemia. She doesn't need glucocorticoid replacement and needs close follow-up. So this is transient hypocortisolemia of prematurity. One more thing, that due to paucity of the labial fat, there can be prominence of clitoris. So you have to measure the length of clitoris before labeling clitoromegaly. So this is really important. Now this is the last question, and this may be a difficult question, but yes, I have put in to complete the list, that this is a 6-month-old boy with micropenis, you can see here, and inguinal hernia here, and mild hyponatremia. This boy presented with small phallic size and inguinal hernia, and he was his P of workup showed low sodium, that is hyponatremia, and high potassium. Cortisol level were low in view of hyponatremia. So what can be action plan, that how you are going to see this patient? So obviously this is a syndromic child with micropenis and inguinal hernia. Yes, any extra investigation you want to do, or you want to ask from my side that extra workup, what extra workup you need? last case, what I'm going to tell, that this setting, that is micropenis, hyponatremia and mild salt wasting, suggests combined adrenotesticular biosynthetic defect. Congenital adrenal hyperplasia is expected to present with more severe defect and earlier onset salt wasting. SLO, that is Smith-Lemli-Opie syndrome, presents with mild salt wasting and androgen deficiency. Further assessment should include examining SLO feature, that is microcephaly, syndactyly, and upturned nares, and of course the lipid profile, what I was wanted from your side. So examination showed microcephaly and upturned nares. Lipid profile demonstrated suggesting of SLO, which was confirmed on the genetic study. So this was SLO with micropenis and salt wasting. So what is the message from this case is that micropenis with salt wasting suggests combined adrenotesticular defect. Considered SLO syndrome with mild salt wasting, androgen deficiency, and low cortisol. So thank you so much for your patience listening. So over to Dr. Amarnath, please.
Yeah, thank you very much, Dr. Vijay. You have covered all the aspects. Please remember CAH and CAS. These are the two areas and which are the common DSDs. They ask the questions. So you have covered the rarer things like limb also. Thank you very much.
Dr. Amarnath, sir, want to say something?
Amarnath?
Yes.
I
Yes,
just
sir.
wanted to clarify one aspect. When it comes to adrenal causes, we don't call it as precocious puberty. Okay, it was mentioned during the discussion that the testes are not enlarged. It is only adrenaceae and pubicae, and that is pseudo precocity. Okay, true precocious puberty, the testicular should be enlarged. But in this case, we should not use the term precocious puberty. We should say pseudo precocity. That's all I wanted to say.
Thank you, sir. So, sir is saying to use the word pseudo precocity rather than a precocious puberty. It's a peripheral precocious puberty. Thank you very much, sir, and sorry for my mistake. So, thank you, Dr. Vijay Jaiswal and team for taking over the whole this session, both ASCII and the CAH. With the expert, we have kept only one case. Actually, for each session, we are doing two. So now we are going to the second session, that is a DSD part. So this would be by Dr. Sudha Rao, Professor and Head of the Department, Neonatology and Endocrinology. She is a excellent teacher and also my mentor, author for many textbooks, and our pet program coordinator and teacher also. So we would like to listen an excellent lecture from Dr. Sudha Rao from Wadia Hospital, Mumbai. Over to you, madam. We have sufficient time of half an hour.
Are you able to see my slides?
Yes, ma'am, they are visible. They are in slides format.
Huh?
Yes, ma'am, your slides are visible.
Okay.
Thank you, madam.
Okay, I'll do a quick, what is it called? Try to make it quick. I know it's 8:40 already. So I'll try to make it as simple as possible, though it is not so easy to make it simple in such a short period of time. We heard a lot about the case presentations were very insightful, and there were many aspects which were discussed in that case presentation. So DST is not an uncommon disorder like the case presentation pointed out. When we say DSD, the commonest cause of DSD we have already seen, which is a medical and a social emergency, the CAH. But 1 in 4,500 babies are born with any type of genital anomaly. And we know that DSD is defined as non-congruence of chromosomal, gonadal, and anatomical sex. When they are not congruent to each other, that's when it is called a differences. It's no longer called a disorder. It's called differences of sex development. And to understand this concept, we need to know where all this is starting from. It is starting from this SRY gene, which is the Y determining region in the short arm of the Y chromosome, which is the main chromosomal moiety which determines the gonadal sex. We have to start somewhere. So the starting point of DSD is assessment of the chromosomal sex, and the chromosomal sex is the one which determines the gonadal sex. Like you can see in this Y chromosome, SRY is present on the short arm of the Y chromosome. You have the androgen receptor gene, which is there on the long arm of the X chromosome. You have this DAX1, which is contiguous with glucokinase and DMD genes, and the ATRX gene. So there are many more genes which have been now delineated and identified in these chromosomal positions and parts. So presence of SRY in the bipotential gonad, which comes from the urogenital ridge, in the presence of SRY gets determined as testis, which differentiates into Leydig cell and Sertoli cell. This Leydig cell further produces testosterone and an INSL3, which helps in testicular descent. And the testosterone in turn gets converted to dihydrotestosterone. Both of them together help in differentiation of the internal genitalia. The Sertoli cell, the main job is to produce the anti-Mullerian hormone, the Mullerian inhibiting substance, which causes regression of Mullerian structures in males. So this is ontogenically programmed to start from 6 to 7 weeks of life, 8 to 10 weeks of life. The gonadal sex gets determined, then you have the genital sex, and then the phenotypic sex, which is seen at the time of the birth. So the problems can happen if the bipotential gonad does not get determined as testis. So there is a problem of determination. If it is determined as testis, does not get differentiated into Leydig cell and Sertoli cell. If it still gets differentiated well, it may not produce testosterone. And if it produces testosterone, may not convert that to the dihydrotestosterone, and hence have problem in terms of differentiation of the internal and external genitalia. So the problems of DSD is essentially due to problem in gonadal determination, gonadal differentiation, differentiation of the internal and external genitalia, and of course the most common form, which is not part of any of these, is because of abnormal hormonal milieu. So this is how the pathophysiology of DSD can be divided into. There could be overlaps, there could be hidden, meaning subtle forms of the variabilities, and hence some of them could be spectrum of a single disorder. So when we look at this child, like I said, atypical genitalia or genital anomaly, we should refrain from calling it ambiguous. Again, ambiguous genitalia is a derogatory word. So you should be trying to call it atypical genitalia, which is not so uncommon, like I said, like it was mentioned before also. It's not an uncommon thing to find. So we as people who are going to attend such deliveries and see such babies in the, say, labor room or later on in the NICU or pediatric ward, should refrain from giving a gender kind of, sex kind of terminology to the various parts. So you should be referring to the baby as your baby, calling the prominent thing as phallus, call it as folds rather than labium or scrotum, and identify the structures as gonads. So you should be not calling the baby as the structure as penis, testis, clitoris, labia, ovaries, which all puts in a kind of determinant sex identity in terms of when you're discussing about a case. So refrain from using these terms and try to find out whether this baby has indeed an atypical genitalia. Are there any syndromic features associated? Is there a failure to thrive or a growth affection? Are the gonads palpable or Mullerian structures present? This is a tick box kind of an approach to dealing with understanding the underlying etiology and pathophysiology of the child with DSD. So there could be various babies there could be various presentation of a female looking genitalia. So this is a prominent clitoris with a penoscrotal or a perineal kind of an opening. This is prominent clitoris with fused labioscrotal folds, and you may have a female looking genitalia with labial masses or no gonad palpable with prominent phallic structure. And at the same time, you can have a male looking phenotype where you may have both gonads descended with perineal penoscrotal hypospadias. You may have one gonad descended with hypospadias. You may have micropenis with both gonads descended, micropenis with no gonad palpable, or a severe form of hypospadias with no gonads palpable. You can have a spectrum of atypicality, but what we must understand is when do we say it is a DSD and not a developmental variant? For example, this extrophy, cloacal extrophy, does have some degree of genital atypicality. So this must be a variant of developmental defect rather than a true DSD. Bifid glands, prominent clitoris in premature babies, an epispadias or an aphallic kind of a structure, vestibular anus. There is a kind of opening which is for urethra, the urogenital sinus, and then your anal opening. So you can have a confluence of various orifices, vestibular or cloacal anomalies, but these are not atypical genitalia. So the first question is to do a good examination to see where is the opening and is it indeed a atypical genitalia. The next question to ask is there an associated syndromic feature? Like in Smith-Lemeli-Opitz, you may find a cleft lip, cleft palate. You may have spinodactyly, you may have a prominent thumb, you may have some hypoplastic thinner eminences, a polydactyly as you can see here. So these could be seen, you need to see for various dysmorphic syndromes, and you have a list of them associated with or assigned to one genetic defect. For example, if you have in a Smith-Lemeli-Opitz syndrome, you have DHCR7 mutation, which has post-axial polydactyly, typical characteristic features, and cleft palate. The Pallister-Hall syndrome, which we see more often, maybe many of you might have seen in your NICU postings, can present with mesoaxial polydactyly, bifid epiglottis, and hypothalamic hamartoma. Or palmoplantar keratoma, predisposition to small. So you may have associated dysmorphic syndromes, which you should look for to delineate the underlying genetic defect. The next question to ask is there a failure to thrive or affection of growth? So in failure to thrive is essentially because of deficiency of aldosterone, which is commonly seen in the spectrum of CAHs, where you may have an underlying problem of one of the 6 enzymes which are required for cortisol mineralocorticoid synthesis. So the various enzymes are shown in this pathway. The commonest one is 21-hydroxylase, which you discussed just now. And we also heard that they can present as failure to thrive, or they can also present as tall stature because of excess androgens during childhood and become finally short as adults. So statural affection, growth affection is the point which you're supposed to see and look for whether the gonads are palpable or not. When bilateral gonads are not palpable, the most common diagnosis is CAH in an XX individual. You can also have an XY CAH, the 3-beta HSD in the higher forms of undervirilization where gonads will not be palpable, something similar to this. Ovotesticular DSD, XY gonadal dysgenesis. When you have single gonad palpable, it is more likely to be a 45X, 46XY gonadal dysgenesis, where one side has become a streak gonad and the other one is nicely formed and descended. It also represents ovotesticular DSD. When both gonads palpable, the next common condition or one of the more common condition which is not a life-threatening situation unlike CAH is bilateral gonads palpable where you have spectrum of XY DSD. So Then you need to see whether the Mullerian structures are present. So when the gonad is determined as testis, differentiated with Sertoli cell producing AMH, you would have regression of Mullerian structures. So Mullerian structures would be present typically in an XX DSD, will be present in an ovotesticular DSD, XY gonadal dysgenesis, the side where the gonad is streak and not developed or differentiated into Sertoli and Leydig cell, and hence AMH is not produced. That hemi-side Mullerian structures, hemi-uterus, hemi-fallopian tubes, could be present. And you do have an XY persistent Mullerian duct syndrome. Mullerian structures would be typically absent in bilateral gonads descended XY-DSD. So the rest are the other more complicated or more intriguing scenarios where you have Mullerian structures present in an XY kind of an individual. So the last question to ask is what is karyotype? Like Dr. Rajni said, it takes really sometimes 2 and longer weeks for the karyotype to come through. So we now do the SRY fish to find out whether SRY gene is present and then take it forward. But of course, the full karyotype is required, especially if you're dealing with like XY, 45X, 46XY, gonadal dysgenesis, etc. So what laboratory investigations would you do? This 1-month-old presents for wanting to know what is the sex of the child. So will you investigate this baby? Which babies need investigation? These are the ones with perineal hypospadias, like I showed in the picture. Absence of one or both gonads with abnormal looking phallus. Asymmetric genitalia. Systemic illness in the form of, say, failure to thrive, hyperpigmentation, shock, with atypical genitalia, any family history of previous siblings or any family member affected with genital anomaly. When you have extragenital or genital anomaly, virilization in the mother. These would be the conditions where you would want to investigate. So what test? You could go stepwise if the logistics are, if your availability is limited, then you may do the Mullerian structure ultrasound as the first step, which is often available in many healthcare services. You would want to do the SRY fish, the assessment of Mullerian structures, the presence of Leydig cell functionality by doing a baseline FSH, LH, testosterone. We know the first 3 months is a golden period of mini puberty, especially so in the first 6 weeks of life. So there is a stimulation of the axis, and hence FSH, LH, testosterone would be useful like a stimulated level, GNR is stimulated level, if the child is coming to you within 3 months of life for evaluation. Otherwise, you may do a HCG stimulation test to find out the Leydig cell reserve. You may also do the ACTH stimulation test if there is a testosterone biosynthesis defect, which is associated with sometimes the cortisol synthesis issues like spectrum of CH. In dysgenesis gonad, you may look at biopsy and genetics, which is now very easily available in various parts of our country and at an affordable, relatively affordable cost as compared to what was available, say, 5 years back. It's very easily available now. But what to do with the genetics is what is more important. Like this busy slide, you may start with the fish and then look at Mullerian structures and then do your hormone evaluation, try to determine the underlying diagnosis. This is in a prominent journal. I guess this is available on the net also. Anybody interested can download this algorithm. So just one case scenario just to understand what we have learned. So this baby comes at, I think, 6 months of life, born term with SGA. And when it comes at 6 months of life, this is how the weight is and the length is. There are no dysmorphic features, bilateral gonads palpable. There is a penoscrotal hypospadias. Scrotum is well developed, is rugose. What do you think is this phenotype? Anybody awake and listening can answer. So both gonads descended is likely to be a undervirilized male. So you have a possibility of this child being a case of undervirilized male, that is a 45-6XY DSD. This child would not have the Mullerian structures present. So the phenotypic description is severe hypospadias with bilateral gonads palpable. When we say gonad descended, well palpable, well formed, it's likely to be a testis. So you do use the EMS score for finding out the degree of undervirilization or masculinization of the external genitalia, and a score less than 7 is suggestive of a atypical genitalia or an undervirilized male. So when you have both gonads palpable, it is XY DSD, and you do not expect the Mullerian structures to be present. So this child did have testosterone, which was 0.2 nanogram per ml at 6 months. Maybe not stimulated, he was not in the puberty, in the mini puberty. So the post-HCG testosterone rose from 0.2 to 1.9, and the ratio, testosterone to dihydrotestosterone ratio, which is used to depict the 5-alpha reductase deficiency spectrum, was normal. So we had a child with XY-DSD, maybe a partial androgen insensitivity syndrome. So the problem in this child was because of a problem of differentiation of the internal and external genitalia. So I've tried to show you through the algorithmic approach about the various possibilities, but every case teaches you it's not so simple. And there are much more complicated issues in terms of management as to what gender of sex of rearing you advise, the gender identity, role, and orientation issues when they are older in age group, management, peripubertal interventions, surgical fertility issues, and risk of gonadal malignancy. There are so many factors which affect their outcome. Gender assignment, I can very well tell you, is an imperfect art. There is no black and white, and you may more often than not be on the wrong foot. And once you go put these children through some, say, surgical procedure, it is irreversible, especially surgical procedures. So we need to be looking at doing procedures, meaning stalling them as far as possible, but once done, the correction stroke damage is done, so it's irreversible. So socio-cultural norms and forces also affect the outcome. There is a high level of gender dysphoria in some of these children with DSD. There are various patient advocacy groups which Dr. Rajni spoke about, which is not so rare in India, and the voices are louder, so much so that legislations are happening as to whom to intervene, whom not to intervene. And there is more knowledge that is required, not only in terms of understanding the pathophysiology as specialists, but also creating awareness as to how to approach a child who comes to you with DSD. And legislation should be helping these children to not face any damage and compromise their adult life. So there are various factors which affect the outcome. Just to conclude, approach is based on these answers to these 5 to 6 questions. And we do have a spectrum of DSD. The more we look at them, maybe we may be able to, plan our investigation and management. And it was not an uncommon thing. DSD is not something which is just emerged in this century. So our Indian mythological stories, even Nuremberg Chronicle speaks of Ardhanarishwara and this portrait of the third sex. So with this, I would like to thank you all. Thank you.
Once again, I thank Dr. Sudharao Madam. So when I went to Wadia for learning, we used to see all the rarest of the rare SF1 deficiency, DAX1 deficiency. They used to run the clinic from morning 9 to 4 without any interval. So I'm grateful to you, madam. And
Thank
any
you.
other points you have noted from our presentation, or just we want your comments on this program?
No. This format is excellent. Presenting a case and having an expert to comment on the case. I think those who have attended are very fortunate to have been able to express and learn. It's good.
Yeah, thank you very much, madam, for making it very simple. I know we used to run away when I was DCH and all. Whenever DSD has CAH, they are asking that pathway and all. So even now, that should go up. That is the aim of this program. So it is very easy once you understand. It is just like maths. So without any waste of time, we'll go to the question and answers.
Thank
And
you.
final, thank you, madam.
Thank you to the organizers for having me here. I would like to leave.
Yeah, please, madam. Thank you. I know you are
Thank
very
you,
busy.
ma'am.
But of that,
Thank you.
madam has given time.
Bye. Bye.
Great salute.
Thank you, ma'am.
Thank you.
Bye. Thank you.
Thank you.
Yeah, just within 1 or 2 minutes, we'll look what are the theory questions asked in DNB, and after that we wanted to have some interesting scenarios from Dr. Raghupati sir, so that you will get interest into this subject of pediatric endocrinology. You will never leave pediatric endocrinology if you sit with Dr. Raghupati sir. So we have time. I request after this question answer session or question session to say few scenarios interesting to the students and to me also to learn. So if you take question and answers, theory questions, so mainly 3 areas you start concentrating. One is the development, that is embryology. Second thing, the CAH pathway, that is the steroidogenesis. Third one is emergency, that is CAH. And fourth area commonly asked now, especially in DNB, is counseling, that is legal questions they are asking. So please concentrate on these 4 areas. And fifth one, which is most important, is the newer terminology in DSD. So previous questions were on describe normal sexual differentiation in fetus and classification of disorder of sexual development, explain synthesis of steroid hormones, discuss karyotype abnormalities, clinical features, management of true hermaphroditism, nursery evaluation of newborn with suspected DSD by history, physical examination, and diagnostic test, issues in management of DSD. Just now we have discussed. We don't know which sex has to be read, what are the legal guidelines, like that. There are so many issues. How to titrate the hydrocortisone and sex steroids. These are the common issues in management of DSD. Approach to neonate with disorder of sexual development. Outline biochemical consequences of defects in classical CAH, that is 21 hydroxylase deficiency, and its management. Management of CAH. You need to write even starting from the newborn period to the puberty. So how to adjust, you have listened already. How to do follow up and transient shifting from adolescent to the adult period, and including fertility. So that everything you should know about the management of CAH. Diagnosis and prevention of CAH. This we have not touched, but you should touch and read about what treatment you should give when the fetal sex is female, especially. So for prevention. Clinical features of classical CAH. So these are the previous questions asked in DNB exam. So I thank each and everyone, especially Dr. Javinder, who prepared this program and taken active participation. I thank everyone, especially Dr. Vijay Jaiswal for taking and leading us in this program, whole and soul. Thank you very much, sir. Now we request Raghupati sir to share one or two scenarios which are very interesting from his life so that we'll learn and make pediatric endocrinology eternal. Thank you, sir.
I just wanted to say examination of the genitalia in a patient is very, very important. And one of the cases that I must have mentioned many times, and maybe
Sir, can you be little louder, sir?
Amarnath also may
Little
have
louder, yeah.
heard about this. I was seeing a staff child in Vellore and for rickets, and this child was coming regularly for follow-up. And the child was 6 or 7 at that time. From the age of 1.5 or so, I was seeing this child regularly, and the rickets improved. And I was so happy because it's a staff child, they were regularly coming. Around the age of 6 or 7, she came with abdominal pain. You know, I was a pediatric professor, so as pediatric case, I had to see this child. I wanted to examine the abdomen. I undressed her, and to my horror, I found that the genitalia was not looking normal. I thought she was a girl, and I found two globular masses in both the labial folds. This was a case of adrenal androgen resistance. Okay. And before that, after I trained in pediatric endocrinology, I didn't want to miss undescended testis. Okay. For a pediatric endocrinologist to miss undescended testis would be the end of that person's career. So I used to pull down the pants of all the boys. When they come for even cold cough or something, I used to examine for the genitals. And after this girl, so I started pulling down the skirts of all the girls also, because I didn't want to miss anything. And quite often we can even see atypical genitalia, which the family was hiding, which they don't tell you about. So that's the case scenario which I've been telling. And there was a question raised about males being missed, not in my clinic, because I was emphasizing the importance of pigmentation. We are very great experts. In India, we have different shades of pigmentation being mentioned all over. And if the child is more pigmented than the parents, you have to suspect. Just with that clue, my postgraduates had picked up so many males with CAH, and any foreign visitor who came to the clinic was surprised that we had more males with CAH than in their clinic. Percentage was definitely more. And this was picked up by just hyperpigmentation, investigation for that. And where to look for pigmentation? The entire skin, of course, but nipples, umbilicus, and genitalia. These are the 3 areas which you should examine for hyperpigmentation. And I'm sure I can assure you, it will be very rewarding. And we have made a diagnosis. Non-salt losers, just virilization. That virilization also cannot be obvious quite often in males, but just by the hyperpigmentation, we have picked up so many cases. And those are the clues which will help you to make a right diagnosis. I mean, I can go on talking, as I said, but I would like to stop with that, and this may be very useful sign. And my own grandmother used to ask, she was a very popular lady, and she will be asking somebody in the street, "Oh, you delivered recently, is it a boy or a girl?" And they used to say boy. and she would like to see the boy, and she will palpate the testes. It was a very, very good habit. But I was offended as a small boy. What is this grandmother going and touching everybody's genitals? And she had a very, very important lesson which she had learned over the years. And she has picked up so many undescended testes or empty scrotum. And so I think, though it may sound funny, but it will be a very useful clue for endocrinologists. Okay, thank you. Thank you for asking me. But I'm very glad that this program is going on, and it is today more than 100 postgraduates have attended, and I'm sure that the interest is growing. In fact, one of the panelists today was scared of endocrinology when as a student they used to mug up and finish the exam, and was not interested in endocrinology at all. But today she was a panelist. Okay, I don't want to reveal the names, but developed so much interest in pediatric endocrinology. And that's the idea. We want to sow the seeds of pediatric endocrinology among postgraduates and inviting them to take interest. And I'm really, really glad over the years, pediatric endocrinology has grown so much all over India, and children are getting benefited. Thank you very much.
Yes, you have truly said that it's a growing specialty. In our DM exams, when 2-3 years ago, when PGI was conducting DM exam, maximum students fill the form for DM endocrinology, pediatric endocrinology among all pediatric subspecialties. And last year in NEET also, NEET INI also, the pediatric endocrinology is a top sort specialty. So now people are coming towards pediatric endocrinology. Thanks to docents like you who have paved the path for juniors like us. Smiles to those. Thank you, Ernest.
I thank everyone, especially Rishabh Gupta. I know it's a very difficult case. You have tried your best. You are the maximum benefiter because you have answered. And I thank
Thank you so much, sir.
Ayush,
Thank you.
Ayushi, Dr. Ayushi, and all other postgraduates, Dr. Ritika, and all the group. I know it's the most tough case, but you have answered very, very well. Don't be nervous. And we are also learning along with you, with our professor. So be fresh.
One
And
suggestion for Rishabh. You were going on saying 2 days, 2 days, 2 days, and that is not right. Okay. And you have followed that child for so long, you should have taken a clinical picture from a later date, not 2 days. Okay. In fact, if you want, you can contact me later by phone, and I will
Yes, sir.
correct your slides and all. I'll be very happy to do that.
Thank you so much, sir. I will surely. Thank you.
finally, I thank Ahila Madam and Rajni Madam, and also Ankit from RX Events for making this event fruitful. And finally, I thank all the participants who were maximum for this session, staying till the end, the 55 postgraduates. We hope you all will pass with good colors. You all will be professors in future. And please take pediatric endocrinology if option is available. That is our request. Thank you, everyone.
Thank
Good
you.
night.
Good night.
Thank you.